What I'm doing here is not simply looking at an X-ray. I'm analyzing how this pelvis is functioning biomechanically under load. The first thing I establish is a true horizontal reference line across the pelvis. This gives me a stable baseline so I can compare the right and left sides objectively. From there, I identify the iliac crest landmarks. In a normally functioning pelvis, these should be level and symmetrical. When they are not, it tells us the pelvis is carrying weight unevenly, and that immediately changes how forces are transmitted through the spine and hips. Next, I draw reference lines across the acetabular roofs. These structures are critical because they show how the hip joints are oriented relative to gravity. Even small asymmetries here can significantly increase joint stress during walking or standing. What we're looking for is symmetry. When symmetry is lost, the body compensates, often silently at first, until pain or degeneration shows up later. I then assess the sacral base plane. The sacrum is the keystone of the pelvis. If the sacral base is tilted, it means the entire spinal column above it is adapting to an unstable foundation. This is not theoretical. A tilted sacral base alters lumbar mechanics, increases disc shear forces, and changes muscle recruitment patterns. Finally, I compare all of these measurements together. This lets me determine whether the pelvis is acting as a stable platform or whether it's introducing abnormal mechanical stress into the spine and hips every time this patient moves. That's the biomechanical problem we're identifying here. Now we move to the lateral view, which allows me to evaluate how this spine and pelvis behave from the side. The first thing I establish is a vertical gravity reference line. This shows me how the body is stacking itself over the pelvis. From here, I assess the lumbar lordosis. A healthy spine has a natural curve designed to absorb shock and distribute load efficiently. When that curve is altered, flattened, or exaggerated, it tells me the spine is no longer managing forces properly. I then draw reference lines along the posterior vertebral bodies to evaluate alignment and segmental positioning. This allows me to see whether individual motion segments are shifting or compensating. Next, I evaluate the sacral angle relative to the lumbar spine. This relationship is critical. When the sacrum is improperly angled, the lumbar spine is forced to adapt, often at the expense of disc and ligament integrity. What this view shows us is not just posture, it shows us how gravity is interacting with the spine over time. This is where chronic stress patterns begin, long before severe symptoms appear. Now we compare the lateral view on the right side. The reason for this comparison is simple. The body does not fail symmetrically. I re-establish the same reference lines so the analysis remains consistent. Any changes we see here are meaningful only because the measurement process stays identical. What I'm looking for are differences in segmental alignment, curvature, and load distribution compared to the neutral lateral view. If one side shows increased compression, altered curvature, or segmental shift, it tells me the body is favoring one side during movement. This kind of asymmetrical loading accelerates joint degeneration and often explains why pain appears on one side first, even when the problem originated elsewhere. This view helps confirm whether the biomechanical dysfunction is global or side-dominant. Finally, we analyze the left lateral view using the same biomechanical framework. Again, consistency matters. Same reference lines, same landmarks, same measurements. What I'm evaluating here is whether the left side is compensating differently than the right, and whether that compensation is stable or unstable. When we see measurable differences between right and left lateral views, it confirms that the spine and pelvis are not functioning as a unified system. Instead, they are adapting under unequal forces, which places excessive strain on discs, ligaments, and joints over time. This is how biomechanical problems persist, not because the body isn't trying to heal, but because it's working from an unstable mechanical foundation. Identifying that foundation is the key to effective long-term correction. What you're seeing here is only a portion of the work that happens behind the scenes. This detailed biomechanical examination and evaluation is performed outside of the time we spend together in the office. A significant amount of careful analysis, planning, and clinical decision-making goes into constructing an effective care plan. That planning is vital because recovery is never one-size-fits-all. Every patient is different. Each person has a unique mechanical problem, and therefore requires a solution tailored specifically to them. Our goal is not just to treat symptoms, but to identify what is truly causing the problem. We can then design a care plan that addresses that individual's specific needs. That level of precision is what leads to meaningful, lasting recovery.